We are going to go ahead and get started. I'm Katie Green. I'm the VP of Marketing at Current Health, and I'm excited that you joined us for our conversation today on Migrating Advanced Therapies Outpatient, some operational insights from UCSF. Here's a quick look at our agenda. I'm going to pass it off to Matt in a second to talk a little bit about Current Health. Then our guests are going to walk us through UCSF's journey to build outpatient pathways for advanced therapies. We'll have a bit of a discussion, and if we have a few spare minutes at the end, we will take some questions. So please drop those in the Q&A box as they come up for you, and we will do our best to get to them at the end of our conversation. Pleased to be joined today by two experts from UCSF. We have Janelle Smith-Hernandez, the Director of Operations for UCSF Medical Center, and Tricia Estacio, Director of Nursing for Parnassus Infusion and Apheresis at UCSF. And hosting the conversation will be our CMO from Current Health, Dr. Matt Wilkes. Matt, I'm going to kick it over to you to bring people up to speed on what we're doing at Current Health.
Thanks, Casey. Thanks everyone for coming. I will be brief because I'm the least interesting person on this webinar. So for those of you who don't know Current Health, we are a company that grew out of hospital at home, but for the last 3 to 4 years have been focusing very heavily on advanced therapies, in particular the delivery of CAR-T bispecifics and bone marrow transplantation in the home. Through a number of partnerships, of which UCSF is one of our newest, but also one of the ones that we appreciate and enjoy working with the very most. We've had about 1,200 advanced therapy cases through, primarily CAR-T. In many of our centres, we've made 90% plus patients eligible for outpatient delivery. And one of the stats that we're quite proud of is we have a model whereby patients are issued with technology and access to the Current Health platform, but our nursing team, our clinical command centre, sit in between the patients and the sites, functioning as a triage layer, but also a way of caring for these vulnerable people holistically, looking after not just their cancer therapy and their cancer treatments, but everything else that can go wrong in a kind of frail acute patient group. And when we do use our clinical command centre, we found at least a 22% improvements in adherence to the wearable. So that's wonderful. We focus very heavily on anticipatory care, so CRS detection early so we can have planned treatment in hours, not waking people up in the middle of the night, not rushing patients in for unplanned admissions, and making sure that we do that kind of with full partnerships, both with health systems and with our pharma partners. And with that, one of our favourite partners, as I say, UCSF, I will hand over to Tricia and Janelle, who are going to start with the presentation, and then we will move on to some questions after.
Great, thanks, Matt. I'm going to kick off our conversation. So why did we build an inpatient-outpatient model, or IPOP as we refer to it at UCSF? And really, when the demand for life-saving therapy outgrew our inpatient beds, we built a new model of care. So we really needed to free inpatient capacity and reserve those beds for patients who truly needed hospital-level care. We wanted to reduce avoidable hospital stays, support appropriate patients outside of the inpatient setting. We want to expand access, reaching more patients for our HBC patient population and cell therapy patients. And the impact is really treating more patients more efficiently while also improving the patient experience. Next slide. So just a little background of how we got to today at UCSF. Really, our goal was to develop a hybrid/outpatient program to, again, increase hospital capacity, deliver care more cost effectively, better utilize our resources at UCSF, and enhance the patient experience. The treatments that we evaluated were 3 main treatment types. The first was a MEL auto transplant. We had previously performed MEL auto transplants in the outpatient setting prior to COVID, but brought them all back inpatient during that period of time. The second group were CAR-T patients, or chimeric antigen receptor T-cell therapies, and then bispecific T-cell engagers, or commonly known as BiTEs. And why it mattered to us is we knew that passive monitoring could support a safer outpatient transition. Many therapies require monitoring with risk for CRS and other toxicities, and that's the reason why we have them in-house. Setting up step-up dosing and monitoring historically has always occurred in the inpatient setting at UCSF. And other health systems had successfully moved these treatments to the outpatient setting with remote patient monitoring. I think Trisha's going to take it from here.
Next slide. So give you a little bit of more of our background of when we first went down this path, like what did we need with a remote patient monitor vendor and how we were going to do selection. So this was really a new area for us. We hadn't used remote patient monitoring for any of our patients before. So we really set out for 4 kind of different things we were looking at. One, technical and data. It needed to be secure and private. We needed to make sure it was going to integrate with our EHR system and that the data we were getting was accurate. So we would hope we would get that from whatever RPM we were using. The patient experience. This was really important because we have done other, like Janelle said, other things outpatient, and making sure the patient understood the process was super important. So there needed to be digital and health literacy. It needed to be easy for the patient to use. We know patient compliance can be an issue with things. And so if something's complicated, you're going to lose patient compliance for that. And then it needed to be fit for cell therapy patients. This was one of our biggest concerns, was that when we had looked at some RPMs, they had been doing it for diabetes or patients post-discharge that needed a little bit more coverage or a little bit more watching, but didn't necessarily understand what everybody needed for a cell therapy. So that was really important that whatever company we moved forward with, understood what cell therapy patients were going through and what their pathway looked like. We wanted to make sure that our area was ready, that we had everything set up to make sure we were safely going to transition these patients to the outpatient side. That's the operational readiness. When someone gets admitted, it's all wrapped up in a little package, right? You have the whole team there 24/7. You have pharmacy on site. You have everybody at kind of that patient's beck and call. Outpatient, that was a little bit going to be different. There's an increased workload to make sure that they have everything set up for themselves at home. One very important thing to make sure you have covered if you're moving is what your escalation coverage is going to be. So while current health is the first point of contact, if they encounter something that moves forward and past what we've set up in our pathway for them, who are they going to contact? And do all of those people at all hours know they're being contacted? Staff training is important. Even though in our infusion center, the nurses are taking care of these patients pre and post discharge, and once they move their therapy to outpatient all the time, that setup of that initial onboarding of these treatments and doing it a little bit different, you need to make sure your nurses are aware of it, because they are the first, like you'll be telling them and you think they have it all down. And then the minute something is a little different than what they're used to, everyone is very confused. So a lot of making sure that the staff that are going to be getting calls on these patients or encountering these patients know what's going on and why it's different. And then what resources did we really need to make sure that this was going to be functioning smoothly? Because we didn't want to recreate a whole new program. We wanted to really do what we could internally with the staffing that we already had. And we'll talk about what we needed extra in just a moment. And then financial and reimbursement, what the implementation costs were going to be and what the reimbursement limitations were. Obviously, we would like to always say patient first and patient safety first, but no matter what you're doing, there's some kind of financial and reimbursement considerations. Next slide. So our journey with Current Health and how they support UCSF's care model and some of the things that I had talked about on the previous slide was they have detect deterioration earlier. So if someone goes home without a home monitor, you're relying on them to report their symptoms. One of the important things with remote patient monitoring is that we're getting active alerts from their RPM. So health data triggers timely alerts, supporting earlier interventions, and reducing ED visits. We know with other things in the past, just patients that are normally out, if they get a fever in the middle of the night, they may not call anybody. They may wait till morning and just come into the infusion center and the clinic because they want to avoid that ED visit. So this really lets us know that something's happening early and not fully relying on the patient to let us know. It expands treatment capacity, which is huge. The patients that we are mostly keeping out are only admitted because something may happen, not because something's for sure going to happen. And so by keeping them outpatient, we're allowed to have more capacity for patients that for sure something's going to happen and they need to be in for that higher surveillance. Cost effective. Reducing hospital admissions is a good cost savings with our 340B pricing. That's something we have here. If we can administer a medication outpatient, we get a better reimbursement or a cheaper cost than inpatient. And we have not had, with doing this, any empty beds. We have enough patients to go into the hospital to refill those beds. Fitting into existing workflows. We're still working on our integration, but Current Health does offer integration. So the doctors should be able just to log on to our EMR and see everything that's happening. We have a process in place to make that happen right now while we're still working on our integration from our side. The biggest thing is Current Health delivers their 24-hour 7 nurse oversight, that they have dedicated remote nurse triage, that they're always watching our patients. So we know when we can't be there, Current Health can. And I will say this has been the most important thing with picking the RPM is that the level of trained staff that Current Health has really have been able to support our nurses, our patients to whatever level we've asked for, and are always dedicated to saying, hey, do you need us to do more? Do we need to learn more? And so we have that back and forth with Current Health. That's been really great. And patient satisfaction, our satisfaction's been great. We have patients that have really enjoyed doing this. We've had people in the past choose not to do certain treatments just because they don't want that hospital stay. And so this eliminates that negotiation with the patient, that they're able to just stay at their own home or somewhere else close by, but not be with all the alarms and bells that a hospital setting would give them. Next slide. So as we mentioned a few minutes ago, we really were focusing on 3 different treatments and what days we could save by doing these outpatient. So we focused on transplants, the myeloma auto transplant. Like Janelle mentioned, we were doing this before COVID hit, and it had taken kind of a pause while we were navigating that world. And then it just took some time to get up and running again. And now with remote patient monitoring, we're definitely more comfortable with keeping more patients out than admitting them, knowing that someone's watching their vital signs and has a direct contact with them. Our CARs, Breyanzi, we have done a few full outpatients now. Carvicti, we're still doing hybrid, but we are able to keep them out a little bit longer. I do just want to put a caveat on the fact that we are not using RPM on our hybrid patients that are going to go in, but we've included them in this more IPOP process that we're doing. And then our biggest one has really been the bispecifics of teclistamab and tocilizumab, of not having to admit them in for their step-out dosing. And we're looking at what other bispecifics are out there that we could do the step-up dosing outpatient now that we have remote patient monitoring. So as you can see with each one of these, inpatient, you're not saving any hospital days, but with the hybrids, about 7 days for the CARs and the transplants, and full outpatient, anywhere from 16 to 10 days can be saved by keeping people out of the hospital. Next slide. And I think I'm going to send this back over. Oh, I'm still keeping this one. Sorry, Janelle. Resourcing outpatient models. So going back to staffing, what did we need to do to really make sure that this could be successful? And the one ask that we did have was to have cell therapy RNs. They work as the coordinators for the whole process for us. We have 2 full-time, so there's one here every day, Monday through Friday, and they are really responsible for making sure that everything that needs to be in place for the patient and the staff, from moving this from the inpatient side to the outpatient side, is taken care of. So they do the education with the patients on what it's going to look like to do these things outpatients. They coordinate with Current Health when someone's going to get set up on an RPM. They make sure the patient understands how to use the device. They've helped create our SOPs and worked with Janelle and I to develop the programs to make sure that all the different players, because this is so interdisciplinary. You need pharmacy, you need the infusion center, you need the clinics, the nurses, the APPs. And you also have to let inpatient know what's going on, because it's possible that these patients may get admitted work with the emergency department. So everybody kind of knows that these people that historically have been in the hospital are now outside, and hopefully not, but there may be some times where we have to do an urgent admit and get them in. So they are making sure that everybody around the process knows what's happening. Monitoring and escalation, the remote enrollment is handled by our cell therapy nurses. We did do education with our emergency department, knowing that some of these patients may have to go in. Our process, though, really in preferred is to do direct admit. So if the infusion center is open, which we have nurses on site from 7 a.m. to 8 p.m., the patient will come here first, and we'll see if we can get them stabilized and assess the situation. And then the goal is to get them directly admitted if they need to go in. And then, as I mentioned, education for the admitted departments. And then pharmacy also plays a big role. They are also helping with the patient's education, making sure all their home medications are readily available. And this is, again, all coordinated by those cell therapy nurses. And that was really what the ad was. It was 2 nurses that we added in order to really make this program successful. Everything else was used with current staffing that we already had. Next slide. And now I'll hand it back over to Janelle.
Yeah, so we took a look at the model's impact after the first 6 months. And we had 23 patients that were treated either outpatient or hybrid with Current Health. We had 231 bed days saved. And all of those were backfilled with additional HBC patients that needed inpatient treatment, such as transplant, cell therapy, or just acute care. We had a very strong EBITDA. So the financial impact was very positive. That did come partially from our 340B discount and cost savings from treating patients in the outpatient setting versus the more expensive inpatient setting. On average, patients were on the monitor for about 6 days. We had an average age of approximately 66 for this patient population. 22% of patients had no clinical alarms, and 85% of clinical concerns were managed without provider escalation. And overall, the feedback that we received from the patients were very positive, that they were able to be in a more comfortable, more familiar environment rather than the inpatient unit. Next slide. Thanks.
Thank you both so much for that. That was, you're really clearly kind of laid out. One of the questions that I'm quite curious about is when you kind of talk about the process and the evolution, you kind of allude to the patients that are included and those that are not. How did your approach to inclusion criteria change, or how has it changed as you've gained more experience? Obviously, the COVID blip aside.
Sure. So, I mean, the 3 treatments that we started focusing on with the auto transplants, the Carvykti hybrids, and the Tech and Talc, we weren't the first people to do these, maybe as outpatients. We were the first people probably to do them the way that we're doing it, and really looking at the hybrid model. But focusing teclistamab and talquetamab, those were the first ones that we went live with the remote patient monitors. And we were very conservative. Everybody was pretty hesitant because we're not outpatient 24/7. And so that was one of the things that made this us a little bit more strict on the inclusion criteria and eligibility to get this outpatient, is that we knew if the patient wasn't doing good in the middle of the night, they would need to be admitted. And so our eligibility medically for these patients was very strict, and they had to meet a lot of parameters, which when we looked at it after we started, a lot of our patients were never even getting to the RPM because they didn't meet the eligibility criteria to stay outpatient. And one of the things for patients people that are familiar with giving Tech and Talc is that you can give Toci as a rescue drug if they run into CRS. And in our outpatient process, we give that up front. So anybody that's going to get Tech or Talc outpatient is going to get prophylactic tocilizumab. And we have seen with that we're not running into CRS or neuro issues. And so when so many people weren't making eligibility criteria to move it outpatient, it was decided, well, let's try on the inpatient side where it's safe. These people that didn't make it outpatient, let's give them upfront Toci, but in the hospital where we could monitor them more closely and they were already admitted. And we found out a N of 10 9 patients had no issues whatsoever by giving them the upfront TOSI. And so now we are reviewing our eligibility criteria to see if we can lessen that and allow more patients to come on the outpatient side. In the beginning, I think our providers were just a little hesitant to all of a sudden move everybody out. And what if they did get into trouble? Because as we showed on the previous slide, our hospital census has stayed full. So that is one consideration. If we move all these people out and they weren't doing well, what were we going to do? We didn't want to overload our already busy ER. We wanted to make sure that they could get admitted when they needed to get admitted. And so doing this little minor study or protocol review to see what happens if we give these people that we thought couldn't get it outpatient TOSI, how did they do? And they did great. And so now we'll be able to treat even more patients on the outpatient setting for tech and talc. Yeah, so that was a lesson learned. And again, that's where it includes the buy-in from everybody, from our myeloma team to our pharmacy to the inpatient team, the hospitals, to let everybody know, hey, this is what we're trying because we want to get these patients that don't need to be admitted out at home.
That's super interesting. Thanks, Tricia. And it makes a lot of sense when you think about that these things are complex. The treatments are changing and they do have to evolve. They can't just sort of exist as one from the off. I guess related to one of your questions, to one of your points about 24/7 opening, we've got 3 audience questions. The first is your infusion center open on weekends?
Our infusion center is open on weekends. And so for patients that are going to be out, but still at their high risk period on the weekend, on Friday, we do staff a weekend coordinator whose responsibility is to make sure that everything, and this has been prior to us moving to IPOP, we've always had this person in a role, but our weekend coordinator is prepping everybody that may come in on the weekend, making sure orders are assigned. So now with this new process, our cell therapy nurses that are managing these IPOP patients work with our weekend coordinator of who's outpatient, where are they at in their treatment. We do video visits with them unless they need to come in on Saturdays and Sundays. If they're not in the period of time where they need to come in, they'll do the weekend nurse will do a video visit, see how they're doing. And then current health escalations get escalated as our nights and evening process for weekends. And it's worked smoothly and we haven't had any issues. And they always can reach out to Janelle and I if there is a problem over the weekend that the weekend coordinators can't handle. But between our inpatient attendings and our weekend nurses, it's gone really smooth.
That's great to hear. Thank you. And again, sort of similar follow-on question. Can you describe what the hybrid plan is? And then they said, does that mean admitting on the scheduled day after drug administration?
Which I personally, Janelle knows this, I'm a big proponent for this. I think this could be a big wave of the future. Is so many of these new treatments, people are not sick or at risk right in the beginning. It's a few days into the treatment and it's pretty predictable. And so what our hybrid program is, they do have a planned admission. So the goal is, whether it's auto or car, to administer the cells or the cell therapy product outpatient. And when we know they're getting to that neutropenic period or that high risk CRS period, to admit at that point. And so you're saving, you're getting the cost most places of the outpatient infusion. You're saving the beds where they would be admitted, just waiting for something to happen or waiting for their counts to drop at that upfront time. So for CAR, we do almost all LD chemo outpatient now. So they get their chemotherapy outpatient. For CARVYKTI, we are mostly doing the cell infusions outpatient, and then they go in a few days later. And then we have now started doing Breyanzi full outpatient, and we did our first autolus patient for leukemia. With the goal to do that full outpatient, this person did end up getting admitted, but with all of these, you're saving kind of that upfront hospital days and decreasing your bed stays. So, yeah.
That makes total sense. And it's a lovely kind of bridge, isn't it, to fully outpatient stuff that way, particularly as these drugs get better characterized. Shout out for my colleague Nicole Zaredko, who's on the call, who published some work with HCA around when these side effects actually occur by product. And we certainly see pretty much everything in the first 10 days, but there are these kind of noticeable differences. And so it's about anticipation, isn't it? And knowing when to save the beds, when to put people in. So that's really clear and really helpful. And I suppose that leads on to the third audience question, which is what is the admission rate and what is the average days for admission?
So for our tech and talc, we've only had one patient that's had to be admitted, and they were admitted for an unrelated reason. They were having some pain issues. And so we admitted them for pain control. And that's one thing we had talked about with this, is that these patients are sick. And so I think there's so much focus on making sure the treatment at hand is being cared for, that we also have to make sure that while they're outpatient, these other comorbidities that they have are also being monitored. And so it was just a conversation then we had internally afterwards for patients that that do have chronic pain. Is there something we need to look at? As we give them these treatments, is their pain going to get worse, and is their maybe at-home regimen going to not be enough? So those are some of the things that we're taking into consideration as well, especially as we start to lighten up on what the eligibility to be outpatient is. Are there other things that we need to look at that we make sure are being managed that would maybe be managed in the hospital historically?
Again, that makes a lot of sense, and it's so easy because these drugs are so new, and they sort of come with CRS and ICANS to not forget, because we don't forget, but at least to kind of slightly take a back seat in the fact that the journey that everyone has been on to get here is, you know, so much, and what people have accumulated on the way. And I suppose that leads into the last audience question, really, which is, and also a lovely note to end on, which is, what are you hearing from patients and specifically from caregivers?
Yeah, I can take this one. It's been extremely positive from both patients and caregivers. In fact, our first patient said, why wouldn't everybody want to do it this way? So incredibly positive. Patients are feeling like they're more connected with their families. They're loving the fact that they're not getting woken up all night by monitors and the chaos of the inpatient units. Caregivers are appreciative because they can manage to be with their spouse or their sibling or what have you more throughout that period of time. And it's easier on the caregivers to not have to take off this incredible bulk of time as well, having the current health be a supportive mechanism for us. So it's been incredibly positive from our patient population. I don't know, Tricia, if you have anything else to add.
No, I think, yeah, just to echo what you said, it's been positive all the way around from patients and staff, taking care of the patients as well to be able to keep them out of the hospital.
I mean, that's wonderful to hear. Thank you. And again, on this side, we can get very focused on the tech and the platform and other things. And it's so when you hear that actually it's doing well in the real world, that's this kind of wonderfully reassuring thing. We've actually got a couple more questions, and we've only got 2 minutes left. One of them is, do you have SOPs for each individual treatment? So CAR T versus auto versus BiTE?
So we do have our SOPs are separated out in that realm. So the CAR T is the CAR T SOP. We don't have one for each individual CAR T. Tech and talc are grouped together in an SOP, and then auto is a separate SOP. So from that realm, yes, but not broken down where Breyanzi has a separate one from Carvykti has a separate one. Those are all kept together. And then we wanted to get moving on this. So we are also in the process of creating an SOP for how we're going to use RPM in our area and within HBC. And that was kind of one that we put the cart before the horse a little bit, because we wanted to see how it was really going to work before we wrote out our whole SOP on what our remote patient monitoring was going to be. So we will have a separate SOP just on RPM as well.
That's a very practical approach, isn't it?
Yeah.
And in the last minute, one more question. Actually, it looks like it's a relatively huge question, but how has the response from payers been to pay for the RPM?
Yes,
so we chose not to explore that at this moment of billing for the RPM. The cost savings and the win everywhere else of keeping these people outpatient, getting the cheaper outpatient pricing, and being able to backfill our beds has made any cost of what current health is charging us somewhat insignificant, to be honest. I don't feel like the amount that we're paying for current health support that was a wash in everything else that we're saving, if that makes sense. At some point, depending on how big the program gets, we maybe will investigate billing for the remote patient monitoring, but that wasn't a big driver for us. We really wanted to get these moved to the outpatient setting first.
Yeah, I
That
echo what
makes
Tricia
sense.
said.
That makes sense. Thanks, Tricia. And it's certainly something that we are trying to work on along with everyone else, is how do we get sustainable payment models for these treatments, both in AMCs and 340 eligible institutions and in the community. But I have made a mental note that we're not charging enough, so I'll pass that on to Matt Starr, or commercial head. So that's us at time. I want to thank you both for, again, coming on here, sharing your learnings, for such a clear presentation, and for answering these really kind of practical questions that confront anyone who's attempting to move these programs to the outpatient. So thank you very, very much for that. And I'd also really like to thank the audience for such kind of interesting and pertinent questions. It sometimes feels like you can be shouting into the void of the internet with these things. So it's lovely when you kind of hear back from the audience. And there's just one comment there saying, thanks for a great presentation. So
I did see a pop-up, someone asking for kind of our SOPs or how we did this. You can find me on LinkedIn. We can connect through there and we can share kind of more of our experience if people have more questions.
That's wonderful. Thanks, Tricia. So Tricia, Janelle, everyone on the call, thank you all so much. And yes, look forward to the next one.
Thanks for having us.
Thank you.